Hello, my name is Tom Chenevert, Department of Radiology at the University of Michigan. And on behalf of the Michigan Alzheimer's Disease Center, I'd like to present part 2 of MRI Basics. My target audience, residents in neurosciences, who I view as the future consumers of MRI. The objectives of this podcast are to elaborate a little bit more on the design considerations of the various sequences we have when we are targeting different objectives to manipulate contrast or to improve signal to noise, or in certain instances to image anatomy with much greater spatial resolution. The other aspect I'd like to cover is there's a lot more than anatomy. MRI is recognized for being extremely flexible and powerful in the range of biophysical processes that it can document. And I'll cover that in the second half. So, anatomical sequences are, as expected, to depict anatomy in 3D space. And for that, we have to localize this, the signal. I talked about that in part one podcast. And certain sequences will be tuned to emphasize different types of contrast. We may select specific tissues using chemical shift to make an image of fat versus water, and as I talked about in the part 1 of this series, often we're exploiting different relaxation times. But there's another whole class of sequences that are designed for speed. Often this is done at the expense of contrast or signal to noise or quality of the image, but sometimes speed is more important than contrast. For instance, speed may be required to remove motion artifacts that exist. Often in the abdomen we have a breathing patient. If we can confine our acquisition to a breath hold, then at the expense of spatial resolution, we can at least freeze respiratory motion. Sometimes we want to visualize the motion. So there's another class of sequences targeting motion, and those may be gated or really fast so that we can look in a single series of time frame views of things moving, for example, the heart. Or we may want to look at motions that are confined to the venous or the vascular system. So MR Angiography and MR Venography are techniques that are also done. I view these all as anatomical sequences. We're trying to map out the anatomy in the body. So with a T2 weighted scan with respectable resolution, these slices through the brain may be 4 to 5 millimeters thick, but this can be acquired fairly quickly. And notice CSF is bright in a T2 weighted scan. The vitrea in the eyeballs are also very bright. Those tissues that have long T2 and long T1 can be accentuated this way. With a different type of sequence where we say we need more spatial resolution. Moreover, we want a different type of contrast. Notice the high level of gray-white contrast as well as CSF contrast. So with now sub-millimeter resolution and thinner slices, we may do a multi-minute scan, like say 3 to 4 minutes, and generate this type of an image. And in this case, it's a T1 weighted scan. Notice the bright signals of the eye now become quite dark in a T1 weighted scan. But we're mapping out anatomy with different contrast at different spatial resolution over different acquisition times. Some class of sequences may be in nerve root imaging or in the inner ear, where we want yet 0.5 millimeter resolution. And now we'll not cover the whole brain, but just a relatively limited coverage in the brain, zoomed in to look at, say, the inner ear, in the inner ear exam. Dedicated scans that we do These may be multi-minute scans because we're trying to get high resolution. We have to do a little bit more averaging to get good enough signal to noise to look at these tissues at these sub-half millimeter instances. These are just a 3D view of the surface of the inner ear canal. For abdominal imaging, we have moving organs, and motion is a problem for MRI. So we may want to design a sequence, and notice this is a fat suppressed sequence where the fat is quite dark, but in a 15-second breath hold, we can actually collect data over the full liver and map things out quite quickly in a tolerably short breath hold interval. As I indicated in part 1 of this podcast series, we can distinguish water from fat, and we can make an image of the water-only component, the fat-only component, and even quantify the level of fat content in the liver, doing a combination of water-only and fat-only and appropriate control of relaxation times and so on to look at different level of fat contamination or steatosis in the liver and be quite quantitative. This technique is catching on and is very valuable. Often we'll compromise resolution to freeze the motion in the abdomen to do 1 second per slice in a free-breathing patient, although from slice to slice to slice you'll notice the motion in the body. Usually these are done just to localize things in the body, and then we'll do a more dedicated scan through the anatomy of interest. Angiography, or time-of-flight angiography, exploits the movement of blood from slice to slice. I indicated there's T1 relaxation times. Well, if blood does not have or has not seen prior RF pulses, it comes in with full magnetization, a very bright signal. As it flies into the slice that's being imaged, it comes in with really strong, anomalously strong magnetization. You can make an image, therefore, using a heavily T1 weighted scan where you put the stacks of slices so that blood enters with unusually strong signal. And this is a MIP, a maximum intensity projection, sagittally through the brain, where the brain tissue is quite dark and the blood shows up very bright, and it can be reformatted in any plane. No contrast is given, no traditional angiographic methods of staking a catheter through your body. This is just due to the inherent motion of blood through the tissues. Likewise, we can gear our imaging sequences to more specifically encode motion. So we can encode velocities using imaging. Those imaging gradients can be used to encode velocity and represent it as a phase difference between non-moving tissues. So non-moving tissues can have 0 phase, that's shown here. And so we're looking through the neck, and you can see the pulsatility of the blood flow as a function of cardiac phase. These can be reformatted as well into angiograms, but we're looking at the anatomy of the vessels in this type of scan. Lastly, we can inject contrast again. Instead of looking for compromised blood-brain barrier where the gadolinium agent, typically it's a gadolinium agent, leaks out into the interstitium, here we're using the gadolinium to greatly shorten the T1 time of the blood. And if we do it dynamically, we can look at the filling and of the arterial side as well as the draining from the venous side and look for shunts between those. And I'm just reformatting that in 3-dimensional views in these MIPs. These may be just a few seconds worth of acquisition each, and we'll do it dynamically to look at the whole excursion of the contrast through the system. It can be done outside the brain as well, so in pulmonary contrast-enhanced MRA. Again, dedicated sequences designed and tuned for the existence of gadolinium in the arterial side in this case to make an image of the vascular anatomy. Now, all of the anatomical MRI is what we're doing all the time in the clinic. And really what we're looking at is looking at the macroscopic properties, the size, the contrast, is it heterogeneous, where is it located, and there we're using typically these routine sequences, including the angiography, where we're controlling the contrast, the T1 weighting, the T2 weighting, the proton density weighting, or the angiographic properties of the vasculature. But there's a clear trend to adapt MRI to look at the microenvironment. There, the targeted biophysical properties, maybe the vasculature, but not the anatomy of the vessels, but rather how are the vessels feeding the tissue? What's the blood flow? What's the blood volume? Are the capillaries permeable? What's the level of oxygenation? What's the pH? What's the cellular density? What kind of metabolites do we have? There's a sizable list of biophysical properties that MRI can probe. There's an equally long list of techniques, and this is really just a partial list. Trust me, there's a lot more methods that I'm not enumerating here. And each method, each acronym, there's careers in each one of these things. There's a lot of effort to be able to target and measure in a quantitative way, or at least in a relative way, all of these biophysical properties. I'll focus on just a few that are done routinely in clinical settings as well as in research settings. Those are related to the vasculature, the blood flow and permeability, the oxygenation, as well as the cellular properties in the tissue. And there we'll be using a technique referred to as diffusion imaging. So if we're interested in not the anatomy of the vessels, but how functional those vessels are they leaky? In the brain, we expect normal tissue will have a blood-brain barrier, and if we introduce any kind of a tracer, that tracer in normal tissue would be confined to the vasculature. It should not permeate out into the interstitium. Well, if we do this technique of dynamic contrast enhanced MRI, we are targeting where the gadolinium is leaking out of the capillaries into the interstitium. There's a lot of mathematical formalism behind these methods, but they're based on compartmental models and tracer kinetics, where we can measure the signals dynamically and quantify those curves and extract parameters from our models and depict the tissue with quantitative maps of this transfer coefficient, this K-trans, that relates to how readily your tracer leaks out into the interstitium. It's a dynamic scan. Usually we scan the entire brain. I'm just showing you one slice, and every few seconds, maybe 10 to 15 seconds or so, you'll get another stack of images through the brain, and you can see as we're injecting the contrast, the tissue is changing. We measure T1. This is one of the instances where we do want to quantify T1. So we'll go through an extra set of calibration sequences to measure T1, as well as measure input functions, apply the mathematics, and from that, with great effort and formalism, generate these quantitative maps of K-trans, or the interstitium volume, the plasma volume, or other parameters related to the permeability of that agent in that tissue. An alternative is not to look at the permeability, but the blood flow. For that, often we'll use a technique referred to as dynamic susceptibility contrast, or DSC. The biophysical principle is that when the gadolinium is concentrated in the capillaries as it's passing through that very first time, as you inject a bolus of contrast in the arm, gets up into the brain, capillary may be 1 millimeter in diameter. However, when that gadolinium is concentrated, it really disturbs the magnetic environment around the capillary. Due to the magnetic susceptibility of gadolinium, it will bloom quite a distance from that capillary, and it'll produce a significant signal change. So, if we look at this brain, again, it's done in the entire brain, but while the contrast is flushing through the capillaries, you can see a very measurable, even though the plasma space may be only 5% in this tissue, it produces a 10 to 20 or 30% signal change, so it's very measurable. Again, we'll calibrate things by measuring an input function, a little bit of mathematics and algorithm to pull out things. Often we normalize by normal tissue, but from this 1 minute scan, it's about 1 minute to inject and look at all these changes, you can generate images of the relative cerebral blood flow, the mean transit time, as well as the blood volume. These usually are relative, because we'll normalize by, let's say, the contralateral white matter. But as you can see, we can indicate where we have a hypervascular tumor in this instance. It's quite valuable for looking at vascular problems. Here, a hemispheric stroke will greatly stretch out or increase the transit time. So that's shown as this hyperintense area relative to the normal side of the brain that is best depicted on a mean transit time image or on a blood flow image. Another technique is arterial spin labeling, or ASL. Now here we're looking at the perfusion, but we're not injecting any agent, just the inherent motion of blood from the arterial side, or the coming from through the vasculature, flowing upward. You can disturb that signal by tagging it. You basically apply a dedicated pulse, RF pulse, that erases that magnetization, and you can compare it to when you put that tag pulse on the opposite side of the slice. So we're looking at the inherent blood flow, and it's similar to a time of flight, you may think, but really we're looking at the change in the signal of that water after it leaks out of the capillaries into the tissue. And so we can quantify the blood flow using an ASL technique. You can either do it as a function of phase in the cardiac cycle, or you can do it over many slices. But this technique does not require any contrast agent. It's a much weaker signal. And you may need to do this over 4 to 6 minutes or so to map out the entire brain. But again, it's totally non-invasive and does not require injection of any materials. And it's also more quantitative than the other methods. Diffusion. Our signal source, water, is not holding still. It's percolating through the tissues. Diffusion is, how we can measure diffusion is if we could measure roughly how far any one molecule moves in a certain interval of time, and that's what we can do to quantify how mobile how mobile these water molecules are. We can go through some old mathematics of what's the typical distance that these water molecules cover in a certain interval of time. And it turns out it's just a fortunate break that how the physics of diffusion of water and our imaging are synchronized, that we can typically document when the water molecules are impeded by the existence of cellular membranes and intracellular water, how densely packed these cells are. All of these barriers to free diffusion will generate contrast that is diffusion specific. And it relates to cellular density, how compartmentalized the water is, how organized the water is. So the architectural, the cytoarchitecture of the tissue is all probed well by diffusion. So diffusion weighted imaging, instead of using TR and TE to manipulate contrast, we're using these other techniques. And it's a B value is just a thing that we can measure using our imaging sequences to change the contrast in a way that depends on how mobile the signal is. And so water in the ventricles and in this cyst of this tumor, it's basically free water. It's not impeded by cells, whereas the normal tissue and certain subcomponents of the tumor are dense and they are impeding water mobility. So we can document these differences in tissue by controlling the diffusion properties of the acquisition. So that compared to normal MRI, there's a T2 weighted scan or one where we erase the CSF signal. Now we can look at the mobility of water in this low B image versus this high B image and actually compare these two to make a diffusion map. But notice we have this small infarct due to some vascular insufficiency here that produces this hyperintense signal that we would not easily see on the traditional contrast. Normal tissue is also organized differently. White matter is highly organized, highly directional. And if you look at the myelin in white matter, it turns out that water has a difficult time crossing through all those layers in the myelin. So the mobility of water cross membrane or perpendicular to myelin is relatively low, like 1/4 that of water that happens to be percolating along the axon in the direction of the fibers. So diffusion tensor imaging is basically it's a diffusion imaging technique, but it's very directional. It's looking for anisotropy, that is, it's looking for directionality of the water movement. So by changing the direction of our diffusion encoding pulses, we can look at different contrasts that exist in the tissue. And notice if you look, the contrast is changing quite a bit, and it's changing in the white matter. It is not changing in the gray matter. Organizing that data and doing the analysis, because we know the directions that we've applied, these are usually recast into a fractional anisotropy image where the white matter stands out and areas of disturbance or lack of anisotropy in this case, a tumor. And we can colorize it so that water moving predominantly in the left to right direction is red, and then the anterior posterior direction is green, and in the foothead direction is blue. So you get a sense of not only how organized it is and how anisotropic it is, but what is the direction of that. So that now we can do fiber tracking, which is connecting the dots of this directionality that we've collected in a DTI scan. And you can imagine these fiber tracks, which are really synthetic. They're not the actual images of actual fibers, but they are indicating the level of directionality and where those fibers are going. And you can imagine that this would be quite valuable to a neurosurgeon who's planning his approach to, say, affect this tumor. Blood oxygen level dependent contrast. It's often used and was first applied for neurofunctional MRI or fMRI. The oxygen level in blood affects the magnetic susceptibility of blood relative to the surrounding tissue. We get less signal from deoxygenated blood on a T2 star weighted scan. We get more signal from oxygenated blood on a T2 star weighted scan. So, as it turns out, as the story goes, if you have increased neuroactivity, you're consuming, you need to consume oxygen for that portion of the brain to do that neuroactivity. You would expect that that would reduce the oxygen level, therefore you would get less signal in that area, and you do. You get less signal very transiently because there's another compensation effect where now the blood flow will increase to that area. So the net effect is you have increased blood flow. Yes, you have increased consumption of oxygen, but the net effect is you have an increased signal in a functioning brain doing that task. It's just a few percent, but if you correlate these signal changes in the brain correlated to the task that you're stepping that brain through, you can extract signal that is related to that function. So the typical task-based approach in fMRI of the brain is to turn on some task or have the brain work, say, just motor task, finger tapping, and do that 30 seconds on, or let's say, whatever, 30 seconds on, 30 seconds off, 30 seconds on and off, and just repeat that many times. We have to repeat it many times because, again, the signal changes are pretty weak, but you can then do a statistical correlation and look for portions in the brain that match the pattern of your task. And this data is quite old, but you can see there's, for motor task, finger tapping, bilateral finger tapping, you can have the motor strip is highlighted on this statistical map, which is shown in color, overlaid on a routine anatomical map. Many different tasks have been devised, and neurofunctional MRI is used not only clinically, usually for neurosurgical planning, but also in a scientific context as well. So, in summary, yes, MRI is doing typically mapping out the anatomy at high resolution or high contrast or a little bit of both. It's very flexible in the range of, in addition to anatomy, very flexible to probe a wide range of biophysical properties. I indicated cellularity, blood flow, architecture, function. There's, again, these are the techniques that are used not only in the clinic or not only in a research setting, but are also used clinically. There's a long list of things I just did not get time to cover. Resting state fMRI looks at the connections in the brain without having it do tasks. It's just looking for correlation of signal changes in one portion of the brain versus another. There's tissue susceptibility measurements that can be done. Metabolites, I indicated we're imaging water and fat. There's also a few very weak signals in choline, creatine, NAA, or N-acetylaspartate rather, lactate. Those metabolites can be measured as well. We can even make images of them, but they're much weaker signals, but they have a lot of biological importance for other disease states. So we have specialized sequences that image different weaker metabolites. We can look at the mechanical properties in the tissue, the elasticity, dedicated approaches to do that. And there's many more, temperature mapping and so on. There's so many different things we can do with an MR system. So I thank you for your attention, and I hope you find this information helpful.